Okay, this is why I'm here. A 43-year-old woman is having a sore throat, pain in her throat. She goes to her primary care physician, who does a strep test. It's negative. He tells her it's a viral sore throat. Don't worry about it. She comes back 2 days later, and she's still having the sore throat. It's more intense, and it's radiating out to her neck. He says viral sore throats take a while to get better. Continue to take your Tylenol. And on the fourth day, now the pain is across her throat and down her arms, and she's having trouble breathing. And she goes to the emergency room. And in the emergency room, she is examined. She has fluid in her lungs. She has an EKG done, and she's having an acute heart attack. And everyone is sitting around saying, how can this 43-year-old woman be having a heart attack? She has no risk factors. No one asked her pregnancy history. She had gestational diabetes at age 23, was 25 and 27. At age 23 and 25, after those pregnancies, she had glucose tolerance testing showing she didn't have diabetes. After the last pregnancy at 27, she thought, the other two were negative. I don't need to be checked again. I'm sure it's going to be negative. And she had never been checked again. So I'm here for two reasons. One is that clinicians who ever see a patient complaining of chest pain or an atypical representation that could be cardiac, obtain a pregnancy history and don't send patients home. And so this patient, after each pregnancy complicated by gestational diabetes, would have had something she could do to lower her risk for diabetes and for future heart disease. Thank you.
I'm here because I care deeply about women's ability to fulfill our true potential to the greatest extent possible. And fundamental to our ability to do that is the ability to control our own lives and make our own healthcare decisions without interference or judgment from others. My work involves identifying and addressing the obstacles to women being able to do that. And we're talking about an example of that today, the kind of fragmentation of care, the obstacles that get in the way of women learning that they need to have postpartum screening for diabetes after having had gestational diabetes. Some of the obstacles we face in fulfilling our ability to control our own health care are sexism and racism, a segregated health system, fragmented care, lack of health insurance. As I came to this conference, I thought about women I recently met at a primary care clinic in New York City, pregnant women who are receiving really good care there. But when they went to deliver the baby, they were sent off to a hospital to doctors who never met them before and knew nothing about their medical history. And after the birth, they were sent back to the primary care clinic with no medical records, no indication of what had happened during pregnancy. And so there was, in fact, a deep chasm, as we've been talking about, in their health care that nobody was helping them leap over. My work after identifying the problems is to try to figure out what do we do to fix it. And I hope I can bring some of that experience and expertise to our conversation, thinking about delivery system reform, better health coverage guidelines, empowerment of women, health insurance literacy training, better understanding by clinicians of the kinds of care and understanding and information that women need. So I look forward to collaborating with all of you and trying to figure out how to address this chasm.
I came here as a way to give a face to patients. I had gestational diabetes with all 5 of my children, and I wasn't diagnosed, though, with type 2 diabetes until my youngest was 3.5 years old. I was never tested before my youngest was 3.5 years old. My oldest was 15. I was only tested because I went to the doctor with knee pain, and he said, let's run an arthritis panel. I said, well, while we're at it, can we do a fasting blood test and an A1C? I got a call 3 days later, you don't have arthritis, but you have type 2 diabetes. So my goal is to help other women so they don't have to wait 15 years after their first pregnancy to find out that they have type 2 diabetes. I may have had it for years and didn't know it. And also, with those 5 children, they have an increased risk of having diabetes themselves. And so I'm not just doing it for myself, I'm also doing this for my children.
And when my oldest daughter was born, I had a postpartum hemorrhage and almost died. I went through a 27-hour-long labor, expecting to come out with a brand new baby girl to take home to a fully arranged nursery that I'd spent months planning, but that wasn't the case. And I realized in my work that that wasn't the case for many women. And as I started to process the different emotions afterwards, and I sought help for post-traumatic stress disorder, I realized how little resources there were for women who suffered, in particular, birth trauma and PTSD. A year after I gave birth, I ended up having a miscarriage in public. Just 12 or 13 months later, right back into the same trauma before. And as I sought therapy, I went through a lot of ups and downs. The first therapist I saw was absolutely horrible. And I thought, man, I'm coming in for help every day, and I'm walking out every week, and I'm feeling worse than I did when I came in before. This is awful. So I stopped going, which is what so many people do. They just stop going. So I decided there has to be better out there for us, right? So I did more diligence, and I researched and found a therapist who specialized in birth trauma and maternal mental health. And 12 or 13 months later, I was very strong and feeling confident. But something else happened to me. I was researching for an article for Huffington Post, and it was in the research for that article that I actually realized I was a statistic. I had never felt so marginalized in my life until I gave birth. Seriously, I'm a 40-year-old black woman, and it wasn't until 8 years ago that I felt like, geez, to most people, I'm another statistic. Right after I gave birth, I'm just another statistic. How can I change this? What can I do? So, in thinking about the question, why am I here? It's very clear for me. Statistically speaking, I shouldn't be here. I almost died twice. I definitely shouldn't be here if you look at the statistics. So I feel that it is my responsibility to use my voice across all the genres in maternal health to represent women who've suffered a birth trauma, but in particular, let's face it, African American women who often don't have a voice in these exact conversations. These conversations take place over and over again without our voices in the room. And it's something that now that my work has moved a little bit more towards policy in terms of advocacy and running support groups and these things, I just want our voices in the room when these conversations take place so that we can help clinicians and politicians truly learn what the walk is really like for someone who has suffered something after birth, whether it's a mental or physical trauma. And sometimes they run hand in hand. A lot of times one is the result of the other, right? And so the reason why I'm here is to do exactly what the title of the conference is all about, bridging the chasm. Being with each other in the same space, sharing stories, being with another, really paying attention, active listening to what is happening to each and every one of us, no matter what sort of acronyms are behind our names. We're all human, we're all the same. All of our voices are important. And I'm very thankful to have met so many of you today. I hope to meet many more of you over the next 2 days. I think my 3 minutes is up. The Oscar music is going to start playing now. I've never had to tell my story in such a short time. But thanks again for the organizers to put this conference together. And I appreciate the opportunity to be here. Thank you.
Began my career in nursing in labor and delivery, and I witnessed firsthand as a labor nurse the chasm that we have been talking about, particularly the chasm between what we know and what we do in our clinical care and community care of the women for whom we care. And so when I decided to pursue a PhD in nursing and it became time to really start honing down on what those poignant research questions were that I had, I knew that I wanted to answer questions in this realm of how can we bridge that divide? How can we take better care of women, particularly in this area of postpartum risk reduction for cardiometabolic diseases, things like diabetes and heart disease. And through several turns, I think, that were pretty serendipitous, I was able to conduct my dissertation research in a large tribal community health system in the Southern Plains. And the reason I'm here today is because of the work that started then and the work that has continued since then with these same community partners and now other tribal community partners as well. But I remember one of the first interviews, so as part of my dissertation work, I was conducting interviews with women who had had gestational diabetes in the prior 3 to 5 years. And some of them even brought their little ones with them to the study session, which consisted of filling out some surveys and then doing an interview with me. But I remember one lady came in and she was by herself, and I think she had a 3-year-old or a preschooler at home. And I remember at first, she was a little shy. She'd never been a research participant, and honestly, I'd never been a researcher. So we were both in new ground, and I think we both kind of understood that. But I remember starting to just ask her the questions that I knew were part of my script, and I was asking her questions about what it was like to have the gestational diabetes diagnosis during her pregnancy, and how really that had shaped the way she thought about her risk for developing diabetes in the future or heart disease. And I tried to ask it in an open-ended way so as not to lead her, of course, down any certain path of answer. And I remember she stopped and kind of looked at me and smiled and said, "No one's ever asked me those sorts of questions. And so I need to think about that." And so we just sat for a while and she thought, and then we had what I think was a meaningful conversation for both of us. And it was really that moment that I realized, and maybe later, maybe not in that exact moment, but upon reflection, I realized that I had set out to design interventions to help women reduce their risk after pregnancy. And in fact, that is still very much the work I do 10 years later. But I realized that in that moment, listening was an intervention in itself and was very much worth taking the time to do. And that's why I'm here today. And that's the message I want to leave with you, which is to find a way to hear voices and then to honor and respect what we're hearing and use that in our solutions and do this, just as Tamoria said, hand in hand in a partnered way. To me, that's what keeps me doing the work I do. That's what makes it worthwhile. Thank you.
I kind of really wrote a story, and it's my story, my firstborn. So I'm going to read it so that I don't miss parts because I might get emotional. So 25 years ago, a young South Asian immigrant woman arrives in Boston, Massachusetts on a beautiful spring morning. Hopes of the American dream, a family. Year 1, unable to conceive. Year 2, unable to conceive, no diagnosis. Year 3, 2 painful miscarriages, 6 doctors. Devastated, heartbroken, informed that no investigations will be done until there are at least 4 miscarriages. Year 4, some hope, a new pregnancy, fear of loss, quit my job, intense nausea for 9 months, no weight gain, GDM diagnosed. The diabetes educator does not know my food, and all I have been able to keep down is glasses of milk and some popcorn. Labeled high-risk pregnancy. Arrived in the hospital full term, 37 hours of labor, followed by a C-section because I was pushing when I was not there yet. Sent home with a 102-degree temperature, returned in 12 hours to a much less rosy floor, a difficult nurse, separated from my firstborn, that I had waited for 4 years to hold. Fighting for my life, unable to nurse, bedridden for 5 months, healing an open incision inside out. Yet, no follow-up directed postpartum. 3 years later, returned as one of those 60% women who end up with diabetes because I was a patient folder. Now, with a shattered American dream of the world's most developed country's healthcare system. I wish I had asked questions. I wish I was brave. I wish I had someone to hold my hand gently. Now, a registered dietitian, a diabetes sisters support group leader, helping other women advocate for themselves. Thank you.
I'm a nurse, and so my story began back in 1982, 83, when I was actually an oncology nurse. And I remember holding a young woman's head, if any of you were around in the 80s in nursing. Oncology care wasn't really it was barbaric, actually, while she vomited from the chemo treatment that we were giving her. And I asked her, because she had a terrible diagnosis from metastatic ovarian cancer, "What is it that you want, Jill?" And she told me the one thing that she wanted was to hold her nephew or niece, who she was the godparent for at the christening. She slipped into a coma a few days later, and I kept saying to the organization, "We need to bring the christening here. We need to have it in her room. Why can't we do this?" And I kept getting hit with, "We don't do that here. We don't do that here. Stop asking. We can't do this here." So I did not stop asking. And so when I think about this journey that we're all on, about doing the right thing for the right reasons, finding our humanity, finding our empathy, it's followed me throughout my career, where I haven't been able to, sometimes I wish I could be normal, but I haven't been able to stop asking those questions, to move up in leadership so that I could help folks at the front line always ask those questions: what can I do, what can I do, and do the right thing. But it has not been easy. And so the reflection for this meeting has been that we need to flip this. We can't keep doing the same thing. We're not going to heal people. We're causing a lot of harm from within these healthcare systems that we've built, that I don't think, and I will provoke all of you to think, we don't do a lot of healing. We've heard today stories that we don't heal, we cause harm. And so let's think over these coming year about doing it differently outside of hospitals. Sorry, but they're a big business. We need to take it back to the real people. We need to keep advocating, we need to be empathetic, and we need to have our humanity and do the right thing for what people want. So I would like to be normal and not keep asking those questions as I reflect at this point in my career. Do I keep going to advocate at the bedside, or how can I best do this? I think we're all in this room so that we can really change things, and I'm really hopeful. So thank you.
I'm really honored to be at a conference with such a diversity of voices and perspectives and people here. And I don't have that much to add, but I was invited as a health systems innovator, and so I did want to represent that perspective, particularly the work that we're doing. And I work for an ACO that's based on health centers, federally qualified health centers around Massachusetts. And our health centers, as they're in their community, have brought to C3, our organization, the perspective that very often the most important determinant on a woman's health has nothing to do with the health care she receives. It has to do with the impact of the situation in which she lives, everything from racism to gender to poverty. And so much of our focus has become, as we're putting together our ACO, also thinking about the underlying causes of poverty and trying to address some of the issues. And I've become aware of the fact that when a woman is pregnant, it actually increases her chance of homelessness. And so for women and people with young children, we're really trying to work on connecting them with housing and with ways of ensuring housing stability. And so as we think about what's going to move not just the average in terms of women's health, but really address the disparities in women's health, I just want to keep sort of out there that we keep thinking about the social determinants of health. The fact is, they say that your zip code is more important than your genetic code in determining your health. So thank you for the chance to add that to this incredible discussion.
I come as an advocate and a patient, and I just want to leave a legacy. I have this amazing son who's 26 years old, and at 8 months, I went to my doctor's office, but dragged my husband with me, because I kept getting yelled at every month that I was gaining 15, 20, 25, 35 pounds, and I just didn't want to get yelled at again. So I bring him, and the doctor is yelling now, and my husband thankfully interrupts him and says, "Doctor, she's drinking 7 quarts of orange juice a day." "Oh, shit, let's send you for a blood glucose test." In which case I went, and I was then on a high-risk pregnancy doctor's ultrasound table until I gave birth to that baby. Every single day. No education, got on insulin. I asked why I was doing this. They said just checking the baby, and I had an 8-pound, 8-ounce baby, and I too was hooked up to IVs and this fetal monitor and was not allowed to get up. Before that happened, I was okay in the bathroom. You know, just let me walk around and work it out. I didn't say boo about the pain. And then they had this suction as I pushed for 5 hours. And I was a grade 4 episiotomy the next day. That's what everybody said. "Oh, you're the grade 4. So I found out that my husband couldn't cut the cord because I was hemorrhaging. That's why I had so much pain from them stitching me. It wasn't the birth, really, that was that bad. It was the stitching. And then I found out 2 months later when I called my doctor that they weren't just hemorrhoids, that I had feces coming through my vaginal rectum wall, and I had a fistula. So I needed surgery 6 months later to correct that. And for people that don't know what that is, women in the 1800s had it all the time. And so the second baby, I was pregnant when Stephen was 1 year old. Everybody was amazed. And I had to have cesarean because they were afraid I would need a colostomy bag if I gave birth regularly. So I willingly did that. That was a piece of cake, by the way. And they're awesome. And there was no education other than, you don't have diabetes anymore. That was the next morning after giving birth. So I've been saying for years that people should get checked every 6 months to a year for diabetes. And I am so thrilled to be here and hopefully leave a legacy that I can see. And my legacy is this. You're all awesome in this room. Every single one of you are incredible. But you only have so much time with us, and we need education, and we need support systems, and we need diabetes sisters and cards to be given out at offices for support systems for women, because we need people to understand on a monthly basis that if we don't have support from our family members, you guys can do as much as you want, but if we don't have that peer-to-peer support, we're kind of lost, particularly when we get yelled at for A1Cs. So I'm here to advocate that support is the biggest thing that we need, and Diabetes Sisters taught me more than anyone ever did in the field. And I thank God that I walked around probably for 7 to 10 years with diabetes. I had thrush in my mouth. That's how bad I was when I finally said, "Can you do a diabetes test?" And I found and was blessed 2 months later to find Diabetes Sisters on Facebook. And I went to a conference, and it's changed my walk and my journey with diabetes. It's not something that needs to kill you. It's not something that means that we can't ride a bike or have an ice cream or eat a brownie. It's doable. It's not cancer. But it does need to change, and I hope it starts here. Thanks.
There, I'm here because I was a part of a diabetes prevention program. I'm here to say I'm not diabetic because of that program. It changed my life. It changed. I'm wearing a Fitbit now. I count all of my steps, and I advocate for that. It's a lifestyle change, and it was very educational for me. So I'm a testimony to what education does. But I'm also here, and I was invited to be a part of this before something else in my life changed. Last 3 months ago, I took in a young lady who had been one of my students. She was 2. I was the director of a preschool, and she'd had a stroke last year. And she ended up living by herself after being paralyzed on one side of her body. She was 46. And my husband and I took her in to live with us because we were running to try and take care of her, and we moved her in with us. 15 days ago, she had another stroke. She's diabetic with high blood pressure. So her family has decided to put her on a trach and a feeding tube. That's their decision. She's not my blood, and so I have to go along with that decision. But why I'm here, and I believe things happen in divine order, is that I sat at this table this morning and I was so moved. Because we've decided to do a grant. Because the story, it doesn't end with me, and it won't end with Erica. We need to educate. We need to empower. We need to collaborate. And so I'm writing a grant, and we're going to go back to the Detroit community, and we're going to begin again to empower, educate, collaborate, and to prevent diabetes, and to change health outcomes for African American women, children, and families. That's why I'm here. Thank you.
a maternal fetal medicine faculty member. And when I think a little bit why I'm here, I think back to a story of when I was a maternal fetal medicine fellow. And so it's early in the year. It's 12:30 when the clinic is supposed to end at 12, and the medical assistants are already sort of annoyed because the last patient of the day has been running late. I walk into the room to a scene of utter chaos. So there's a woman who sits there on the table. She's overweight. She looks a lot like many of my cousins in New York City. She's there with her 2 kids who are tearing up the room, and then a baby in the carrier who's about 7 months old. And so I'm trying to figure out what's going on. I look at her chart. I can see that her blood pressure is through the roof. Her blood glucose is through the roof. Her weight is through the roof. And so I lean in because it's the only way I can hear her through all the din that's going on with the kids jumping on the scale. Many of you may have been in these rooms. And so I ask her what's going on. And she says she knows it's not for her. It wasn't that she knew that it wasn't that she didn't know that she needed to lose weight or that she needed to get her blood pressure better or that she needed to get her blood sugars better. One, she missed her postpartum visit because she didn't have transportation to come. And by the time she was able to get back in, her insurance had run out. She wasn't poor enough for insurance. And so she didn't actually want to be pregnant. But here she was at 25 weeks at a first prenatal visit, not having other options. And so the two of us together, we got through that visit. We got through the rest of her care with sort of the best outcome we could have hoped for in that pregnancy. Got her some contraception. But what it left with me was an understanding that my people, my OBGYN people, in some ways have really failed my people, like my African American women who have trouble navigating the healthcare system. And this understanding that we need to get out of the silos. We have this position of honor to take care of women at this one snapshot in their life course. But that's what it is that we have to understand that the period of time in pregnancy is a period of time in a woman's life, and we can't just say goodbye to them at the end of the pregnancy. We need to do better in terms of moving them on and moving them through their life course. So I hope to do that in my work. I hope to do that when I teach. I hope to do that in my own family, with my own friends, and I hope that we all can do better. So thanks.
I'm an epidemiologist, so I really didn't think I had a story, but my lovely group found this story in me, and so here it is. So I'm 22, graduating college, find out that I'm pregnant. I sort of, not a wise decision, marry my boyfriend, and so it's now fast forward, it's time for me to have this baby. I'm in labor. I call my mother. I'm not close to my mother. We actually sort of haven't gotten along for as long as I can remember, but I'm pregnant, I'm having a baby. She's my mother, so I call her. And she lives about 2 hours away from where I'm living at the time, and it's about midnight, and she said, okay, I'm gonna put on a pot of coffee and I'll be there. And I was like, be there? I mean, that sounds normal for other people, but not in my family. So, I go off, this baby comes very quickly, and just as I'm having him, my mother walks in and is there with me. And in that moment, there's this grandmother, my mother, me, and this sort of perfect baby that I have. And we connect in this way that we had never connected before. My mother died 2 years later from cancer. And it turns out that in that moment, sort of my commitment to women's health, to what pregnancy can bring a woman and a family, the power of it, the tragedy of it, the miracle of it can change a life. It changed mine. And it turns out, as I learned today, that my commitment to women's health and pregnancy health and reproductive health, I kind of learned from my mother in that moment. And that's my story. Thank you.
So my story and why I'm here is because the take-home message is that there is a lot of power in working together from so many different perspectives and segments and groups and individuals. And we need to take that and with optimism in moving forward on this particular issue as on so many others. But if I want to drop, the reason I say that is dropping back, say more than 25 years ago, I was a postdoctoral research scientist in an ivory tower not far from in the middle of Baltimore, Maryland, and I was reading the newspaper and reading about this new GAO study, whoever they are, that showed that women were not being included in clinical research studies funded by the National Institutes of Health. And that didn't make any sense to me as a basic scientist. I didn't know anything about clinical research, but it just didn't make any sense scientifically, and I didn't really, it was just sort of jarred me. Now, coincidentally, I ended up working for Congress the next year as a AAAS fellow, and had the opportunity to work on that and many other women's health issues over the next number of years in Congress, in the Department of Health and Human Services, at the FDA, and now back in the ivory tower at George Washington University. But the key lesson I learned from that was that the reason we were successful then in making change then and continuing incrementally over time was through working with so many allies, whether they were organizations representing the spectrum of women or representing different types of players in the healthcare system, whether it was with members of Congress or with the media, with the educational system, with the research community. All of those played a part in the success that did happen over the last 25 years, with ups and downs. Now we face truly challenging times, truly. To keep us from not just stepping backwards, we should still have a vision that reaches higher and reaches more. And on this issue of pregnancy care and gestational diabetes, the long-term health of women across the lifespan, we need to keep our sights high while we fight in defense, that we continue to keep a vision. Because together, that network of allies, and this network of people from all walks, from all over the nation, we can still make a difference. And though sometimes I don't think that right now, I think we still have to keep that vision in order to get to where we want to go. Thank you.
Why I'm here, it starts with a tale of two births. When I was a young midwife in the early 1980s in San Diego, I was caring for a Hmong woman. The Hmong had come as recent immigrants from the Vietnam War. And this woman's baby was having late decelerations. Essentially, her baby was dying. And we said, "You need a C-section." And she said, "No, I won't have a C-section." Now, members of the medical community had made close ties with the Hmong, and we called in the clan leader, her husband. We explained everything. And finally, the woman said to us, "If you cut me open, the evil spirits will come in. I can always have another baby, but I can't get rid of the evil spirits." So I took off the monitor, and I delivered one of the few stillbirth babies I've in my 35-year career as a midwife. But I felt very okay with it. I mean, it wasn't my life story, my picture, but I felt that we had respected this woman and she had made the choice. Fast forward 10 years, I moved to Boston. I'm working at a very large institution, hospital in Boston. Not my patient, someone else. And I hear that this 17-year-old African-American woman, they have gotten a court-ordered C-section to C-section her, even though she refused. And I was quite dismayed. Little earlier, farther on, I go to an American Public Health Association meeting where a social worker is giving a talk titled, "Somalian Women Believe Their Baby Will Come When God Wants It to Come." And actually, she was coming from a very prestigious area of the Midwest where 3 Somalian women had had court-ordered C-sections because they refused to be induced because they were 41 weeks. And 2 of those women refused C-sections and their babies were taken away from them because they were bad mothers. So I am here because we need to prioritize women's health. We need to understand that we respect women's choices and understand that trust women to make the best choices for themselves and for their families. And that if we devalue them and don't understand the social determinants that they bring with them to our health care, that we are going to traumatize them and really traumatize their whole life and their whole family's life. And so I'm here because I think we can all together, this GDM, preeclampsia, all those are really essential. But unless women trust us, they're not going to come for the care. So we really need to think about that. And we really need to trust and respect women. Thank you.